And at this point, let me provide maybe a few minutes for the speakers to interact if you have questions or issues, comments about each other's presentations. Very, very briefly, please.
I'll be bold enough to start here. I like the point about trajectory. We do get very enamored of trajectories. But part of the reason is I think there's a brain reason for that, and that is that, you know, we showed so much of brain development occurring quite early in life when the child does not have much of a behavioral repertoire. After all, we're not electing 2.5-year-olds to be president or anything like that. There's so much of brain development to go, and I think Robert's right that it's a difficult thing to try and project forward. On the other hand, that's probably where our interventions, because of the plasticity and resiliency, where our interventions are most effective, both acutely and scaffolding for the future. So there's a large premium in developmental neuroscience in finding early predictors of later outcome. And they're not really deterministic, but they do provide kind of a guidepost of, do we need to make adjustments to if you will, alter the trajectory. That's very, very difficult. Our success in school, our success in the job market, our success in social life and so on depends on structures that are going to develop much later, late middle childhood through adolescence and even into early adulthood, but whose brain development is very dependent on the early structures and how we scaffolded in the beginning. So I don't know that there's a solution. It's a conundrum, but it's why people are so enamored of trajectories, is to know, are we steering the boat right? How do we get us back on course? So, particularly in vulnerable populations.
Well, perhaps I can just come back on that particular thing. In the field of childhood disability and interventions on their behalf, which I spent some years working at with Peter Mittler in Manchester and some of your colleagues in the United States, one of the conundrums used to be, well, we use these tests to predict, but of course our ultimate goal is to defeat the prediction. So the intervention is actually contrary to the very process of predictive assessment. And I think within the African region, sometimes what I see is a sort of a rather too easy acceptance of these global generalizations. I was horrified just recently driving along a road next to the university in Lusaka to see a huge poster saying, "Did you realize that 40% of our population are stunted?" And that was the entire message. So, I mean, what does it tell people if you're saying this population of which you are a part, 40% of you have already been fundamentally limited? And I really don't believe that. I mean, I think that the limitations are very relative, and the scope for human agency is enormous, not only in adolescence, but why do we have so many gray-haired people around this meeting? Presumably, that period which on your graph shows no brain development, something's happening pretty important between the ages of 20 and 60. Otherwise, we would have all 20-year-olds standing up here. We do assume that 60-year-olds have learned something over the course of their lives.
I did mention that there was neurogenesis throughout the lifespan, just to be sure about that. No, I appreciate that, and I think that that's a very good point. Maybe Maureen wants to chime in on this. You know, one of the issues that we have in the autism world, and I don't treat children with autism, is the late diagnosis. So again, it's that constant watching the trajectory to see. You know, the common answer of the pediatrician is no language. Well, you know, we'll just wait another 6 months. We'll wait another 6 months. And I think at least in autism there is evidence that the later you diagnose and intervene, the more difficult it will be. On the other hand, I think what you're pointing out is there are kids, there's a very wide spectrum of that when that spurt takes off in terms of any number of behaviors. And we should be sensitive to that.
Yes, I wanted to just follow up on I had a question also for Robert I'm wondering about the mental health disorders in children in the traditional African societies. Do we have something to learn from them about about the way a child rearing and play, the importance of play, and things that we might be losing in our own as we rush toward development and doing well on IQ tests and things like that.
I don't have any particular example to offer of interventions of a traditional nature on behalf of children's mental health, but I would say that the emphasis on sibling support has been recognized by the community working at the front end of service delivery in the wake of the HIV and AIDS pandemic, which has hit Africa, sub-Saharan and Southern Africa particularly hard. There's a lot of awareness there that it is siblings who are providing much of that safety net. We hear a lot of talk about grandmothers, and grandmothers are important, but I think the sibling care pattern or practice, which has, as I mentioned earlier, been somewhat stigmatized by some development agencies, is in fact a very powerful socialization process, which is deeply valued by all the African adults that I know, who retain strong relationships with siblings. Whether it's an effective, or demonstrably effective, quantitatively effective prevention strategy for mental health, I would think is beyond the evidence, but I would certainly see it's a promising area.
Well, thank you very much, panel. And I'm going to turn it to the forum members, and I see a few hands already, so I'll be coming to you. Just wanted to maybe a comment, an editorial comment. Looks like one of the lessons we're learning from this panel, it's how developmental scientists may need to learn how to walk and chew gum at the same time, right? Try to be able to think about biological development and its ramifications for future development, while also understanding contextual influences, and how to bring these two things together will be one of our challenges. I'm going to throw out one question and just hope that the question will be discussed or answered during the forum participation. And that is with regard to Maureen's paper, I wondered if the increasing emphasis on the rationalization of early childhood interventions around economic development outcomes could be part of the reason why children with disabilities are often left out, both in our thinking and our interventions. And with that, I'm going to open the floor for conversation. And Zulfi is on, then way at the back. And please come to the microphone so we can all hear you, and possibly also be able to record.
I thought this was a fascinating session. So let me start with two comments, and then I have a question for you. So the first relates to this integration of prevention of disability with everything that we do around survival and perhaps on human capital. And I think we are at a very unique point now with these global action plans, whether they are for maternal and newborn or childhood survival, diarrhea, pneumonia, where increasingly we are bringing in at least the low-hanging fruits around disability prevention. So neural tube prevention, which has received neural tube defect prevention, which has received virtually zero attention at a policy level globally, is something that we could scale up tomorrow. I was pleased to see the reference to hypothyroidism. Even if you do not have the mechanisms to put in screening and all the other elements. Universal salt iodization is one of the most important interventions to reduce some of those disabilities there. And we have evidence for some of those at population level as to how countries within a decade have gone from significant deficiency to no deficiency. So those are things within our grasp, and I would make a very strong case for focusing on things that we can do with the technology and knowledge that we have today, and then work towards other screening programs and detection. I wanted to ask you around the adolescent period. So Michael talked about the scaffolding and the importance of those critical periods that I agree with completely. But what has been baffling to some of us working in this discipline is the increasing evidence of things happening way beyond where biology tells you. So for example, this whole issue of catch-up growth in young adolescents, in the context where a lot of the stunting is early, but yet you see from nutrition interventions that there is a proportion of children who do catch up, even in adolescence, in the school age group, where biology would tell you that this won't happen, but it does happen. So it just gives us a sense of perhaps there is some porosity around the margins of where we think there are absolute limits. And when you come to mental health interventions and the impacts not only in the short and intermediate term, but across generations, I think the adolescent period has been completely ignored. The benefits of some of those interventions to young people around that time, both in terms of their own protection and in terms of their environment, I think has gains that go way beyond their own selves to next generations and so on and so forth. So I think, as I mentioned yesterday in another conversation, some degree of humility is needed in this exercise around what we know today, but what importantly we don't know or need to know a lot better as we move forward.
I'm going to suggest that we continue with the conversation within the forum, and then the speakers might get the opportunity to maybe respond.
Yes, Rana Haji, CDC again. Thank you very much. Really very informative and fascinating discussion. I especially appreciated the multicultural aspect of child development issues. Just along Zulfi's point of linking child development to child health, I mean, as this is kind of a continuum, and since MDG4 was mentioned already by Maureen, I'm just wondering if you could comment on the importance of early childhood infections in general on the brain development. I mean, I work on vaccines, and obviously the effect of nutrition is well known, but we've done work on research on the more severe aspects of infections like meningitis, bacterial meningitis, which results in significant hearing deficits as well as other neurodevelopmental issues, deficits, but also I'm thinking even, chronic ear infections. I mean, it's a very common problem, very little data actually on the prevalence of this problem in developing countries and how much effect it has on overall development and education later for the child. And the reason I'm mentioning this because many of those are very preventable conditions, and this is what vaccines actually are supposed to do in kind of moving from just MDG4 to the other, to sustaining developmental goals. So that's one issue. The other thing, I was, kind of struck by, what Maureen presented on the high prevalence of disability and how as child survival improves, actually this has increased. And, since the task seems so huge, I'm just wondering, a couple of questions first. How much of this increase in disability is real versus affected by the biases of improved awareness, improved surveillance, as well as improved, or the various diagnostic capacities that, for example, Robert talked about. How is this disability being assessed, since I'm not very familiar with that. But also, I'm just wondering, for our future work, since the task is so huge, can we start qualifying more the disability that is more critical to the child, as you all mentioned, full developmental potential? Because then, you could focus on interventions that can be prioritized to address the more severe ones. I think Maureen showed an example on the severe intellectual disability, and then this way it will help us with coming up with kind of a package of interventions that could be used at different levels of child development. Thank you.
I think permit me to change my mind a little bit since the questions are piling up, and let me give the speakers a brief opportunity to respond to some of those issues, and then we'll continue with the questions from the forum.
Well, I'd like to just respond on the issue of brain infections as a cause of developmental disabilities. It's indisputable. And there is evidence from Bangladesh, Pakistan, and other countries as well that a lot of the intellectual disability seen in children is due to preventable brain infections. There's also some work out of Kenya recently looking at cerebral malaria as a cause of autism. So, there's no question. Some of it's vaccine preventable, some of it maybe not, and we have to look to other ways. And then as far as how much of the increase in developmental disabilities is real, I think that I think that what do you mean by real? Because if the society, disability is by definition culturally and socially defined. And it may be relative to what the expectations are of the child and to participate in the society. So I think that if we're recognizing more, is that not real? I don't know. So difficult issues to tease out.
Okay, Michael?
I'm glad you raised the question about infection. I mean, I think that the biology basically is infection first, development second, mortality first, morbidity second. That when we are worried, and the biology sets itself up that way. That is, when one is infected, as I very briefly showed on that one slide, you utilize nutrients very differently. You actually inhibit absorption of iron. So if the goal is to be iron sufficient and you're infected, you're going to have a difficult time achieving that. And that makes some amount of sense, that you want to prevent whatever, iron delivery to the bacteria and so on. So it speaks to the issue of we are very good about the biology of intervention. We're not very good about the biology of receptiveness. And I think as we move along, we're going to see much more thinking about why are our interventions, whether they're nutritional, social, or whatever, effective or not effective based on the receptivity. Part of that, I think, is what Robert was talking about, but part in terms of cultural receptivity. But I think part of it is also whether the biology is set up to receive. A child who is not hearing well, you can imagine, is not going to be receptive to certain things. A child who is infected will not absorb certain nutrients, will divert other nutrients from building the brain to just simply survival mode types of things. So I think more attention when we think about integrated approaches is in what receptive condition is our child.
Okay. And I'm paying attention to time, so why don't I get a few, are you monitoring who goes first, or? Okay, so we have
Let me make one comment about the protein, too, about the adolescents. I think that's a lamppost problem. I mean, people have concentrated so much effort on the early child, as you know, I think they should, that much less, I think, is known about the tremendous brain development that's going on there, and, for example, the nutritional requirements of it. But the fact is that the second highest time of protein accretion on a gram per kilo basis is during adolescence. There's a huge spurt there. And of course, it's to support those higher end functions that are developing there. But I think it represents a tremendous opportunity. And as you and I discussed in terms of neonatal intensive care kids who are stunted, that's a period we see very rapid catch-up growth and development. So I really appreciate you bringing that up.
Yeah, hi, Jody Hyman. Fantastic panel. I guess I want to follow up on 2 points. First, Maureen's comment that when we look at these distributions, we actually have to worry about everyone in the distribution. I just want to second the importance of that and how often it's omitted. I'll take a simple example. Times when I've seen measurements of school performance, early school performance reading, that's as we move globally from just enrollment to how kids fare in school and where they complete, we're going to see more of these measures. They often completely omit kids with learning disabilities or differences of any kind, and we just have to be really aware of that because we're cutting off where all the need is. So we have to dive deep and really look at whether all of these discussions are moving all children. So that's one. The second was to build on what Robert said. You know, I thought your piece about testing and examination was fantastic and applies not only across cultures, but does also apply across learning difference and disability. Kids are often tested for cognitive things using their hands. When they can't use their hands, they're tested for abstract reasoning, using reading for kids who have learning differences that are only affecting reading. So that testing problem that you raise, I think, is important across cultures, but also across learning. I want to make one friendly amendment on the sibling care, which is I do think it's a very important point that care is done differently and that we may get to the same milestones in many places in different ways. But I think it's not just the aid agencies that raise issues about distinguishing some sibling care from children who have to care full-time for siblings. And I say that based on having interviewed thousands of parents and their kids, where both the parents in country say, I wish I didn't have to pull my 8-year-old out of school to provide care for my 3-year-old, and importantly, I think the 8-year-old themselves and the 10-year-old themselves have told us they would rather be in school. So there's also good national data showing that you're at very high risk of being pulled out early if you're a girl with a younger sibling, 0 to 5. So I think we need to distinguish some of what is really differential ways to raise children from some of what is need-based when it becomes full-time caregivers at very young ages, not by either the parent or the child's choice.
Thank you very much. There are some at the back. Alan?
Hi, Chloe O'Gara from the Foundation. Thank you for a really interesting panel. Oops. Thanks for a very interesting panel. A couple of follow-up questions. It was great to hear socially distributed care raised and discussed. Oh, since this is a forum on investment, I'm wondering what we're seeing about changes in socially distributed care with urbanization, with migration, with all of the changes in household structure that are coming on. And it's something we probably ought to be thinking carefully about in our conversations. Jody already raised the gender issue, but in the 12 sub-Saharan African countries where we have time you stayed on care, there's a tremendous gender differential, whatever the care, whether it is sort of predicated on a mother model or a socially distributed care model. So I wonder also what we see in terms of care data and care outcomes for both the caregiver children and the cared for children when we look at some of the trends that are affecting the shape of families and the care that young children are receiving.
Check. Aha. Good morning, everyone. My name is Nicole Benham. I work for PEPFAR. So I'm going to do what I can't stand when people do, but it's also add another comment, which is, we are increasingly seeing that not just HIV-infected, but HIV-exposed infants and young children are experiencing developmental delays. And so I just wanted to make sure when you were talking about infection that we think about it beyond just literal infection, but the way that infection of caregivers can also affect the developmental delays or affect the development of children. And I wasn't sure if you have anything to add to that, please do, because I know Lorraine Schur is a part of this process. She did a systematic review. I don't think she's here today, but I just think given the widespread nature of the epidemic, this is something we really need to pay attention to.
Take just one question, and I want to open it up to those, everybody else, and those participating by webcast. Okay.
Hi, Lorraine's question was very similar to Nicole's. It said HIV infection is associated with cognitive delay in both HIV-infected children and HIV-exposed but uninfected children. To what extent could the HIV epidemic be contributing to the fluctuating figures of disability in high endemic countries?
Alan Pence, University of Victoria. Most of my work is done with indigenous peoples and also in Africa. And I very much appreciated the panel and their comments this morning. It tends to, though, bring to mind one of my key concerns, which is Jeffrey Arnett had summarized as being 95% of the literature coming from 5% of the world's population. And I have this concern. It's reflected in what Robert was saying, that we do not see a growth in the availability of research dollars going into parts of the majority world or the LAMI nations, so that those other perspectives, ones that aren't necessarily going to occur to those of us working in the West or North America, the US, are able to begin to find their place in the internationally accessible research literature. We've just been taking a look at the early childhood literature in Africa, and it's 14% of the world's population of children in Africa, less than 1% coming from African-led research, African researchers. So that issue around the need for support for research led by Africans, I'm using that as an example, and the real difficulty in supporting and promoting capacity around scholarly work, and I think is reflected in the comments this morning.
Okay, I will take one last question, and then we're just about 3 minutes to our time. So, and I'm hoping that questions that are not addressed by the speakers, hopefully will be addressed, during the extra conversations. Yes, please. Yes, Gary.
Yeah, Gary Darmstadt, Gates Foundation. If you look at the physical growth data in children and in the fetal period, it's similar across societies across the world, and it seems similar to predict that neurodevelopmental growth trajectories would be the same in societies across the world. Do you think that that's true, or do you think that the differences in child rearing, child stimulation practices are so profound that you fundamentally would see different growth trajectories, or can we just not measure them effectively? What do you think the situation is there?
Okay, that's specific enough. So, would you take it, Robert? Okay.
Yeah, I take it you're referring to cognitive growth, right, rather than to
Yes.
biological,
Yes.
physical growth. I think I said earlier that I'm a bit uncomfortable with this overemphasis on trajectories. I think the fundamental reservation I have about it is that really it's not just that the brain is growing in adolescence, but a lot of things are happening in the lives of people at that stage of their life journey, which will radically alter the direction in which they develop. So if a child, for instance, completes primary school and goes to secondary school, which typically happens in early adolescence, the journey of that individual is altered in a fundamental way. And you don't need to talk about the receptiveness of neurons to understand that. That has to do with the cognitive structure of human beings and the moral decisions which people have to take if they have pregnancies or such issues arising during adolescence will also radically influence their life opportunities. So, to my mind, the explanatory power of the very beautifully documented influence of physical substances on different parts of the brain during the prenatal and the immediately postnatal period has limited relevance to what's going to happen later on in people's lives. And it doesn't mean that it's not worth preventing children from having iron deficiencies or episodes of malnutrition. But even when we look very carefully at episodes of malnutrition, we have plenty of evidence of individuals managing to overcome the adversity of an episode which is quite serious of malnutrition and move on to great intellectual and social success. So I think we have to recognize, if we're going to talk to parents and to school teachers in rural communities around the world, that these high-tech interventions are really over their head and behind their back, that if we want to engage these communities in progressive social change, we need to look at what they can do. So, for instance, if you look at the research on the adoption of children who were in abusive conditions in orphanages, that certainly is valid information, but it's not necessarily very relevant to the much larger section of the world's population who have different, but not necessarily in any sense, abusive or neglectful forms of socialization, which are simply different from those which Western parents, particularly middle-class parents, have adopted. So until we know what the predictive power of those various types of socialization which are normative in other parts of the world are, I don't think we have a field of scientific knowledge which we can say we now know how to determine and influence developmental potential. That kind of language, I think, is overstated. We have a lot of information about certain specific risks and a certain amount of information about some beneficial interventions. But I skipped over the part of my presentation, I'm sorry for bad timing, about language. But you know, language is being used at the political level around the world in very hegemonic fashion. And you find whole countries' educational system using languages which are not used or barely used in the, everyday discourse. The distortion which that brings to career prospects of people going into formal education is enormous. And in my country, where we've recently had a reform, you have now an awareness at policy level that children should not be taught their initial encounter with literacy in a foreign language, that they should be taught it in the language which they've already become competent at speaking. But the pattern of 20 years of hegemonic imposition of English as a medium of instruction in the early grades has had a backwash effect now, not only into parental socialization practices, but particularly into the private sector of ECD. So early childhood development interventions, typically in Zambia, are being conducted in English, and yet the parents are expecting this will give their children a head start in grade 1, where they will be taught to read in a Zambian language. So it's actually a dysfunctional orientation based on an old-fashioned, outdated conception of which language, how, when, why. These types of things, as Mark Bornstein put in this very interesting recent 2014 SRCD policy brief, uses the term the specificity principle. It's a very hard one to absorb, I think, in terms of scientific generalization. But I think he's absolutely right that, in fact, what matters in issues of this nature is specific to particular circumstances. So a given language in a given society for a given child at a given developmental stage with given educational opportunities will be different from one case to the other. We do not have valid generalizations available for that.
Okay, Robert, thank you very much, and I'm sorry for flagging you because of time. Let me, it's very obvious from our conversations that this panel has generated a lot of issues that I hope we'll be working with, for a long time to come. I want to thank the speakers, the panelists, for doing such a wonderful job. I want to thank the planning committee, which put together such a diverse and complex set of presentations that are enabling us to, go away thinking and processing these over the course of the forum's life. Thank you very much, and we have just about 10 minutes of a break, and then we're back to the second session, which will be moderated by Andy Shi, and it's going to be on the state of the world's young children and caregivers. So see you back in about 9 to 10 minutes. Thanks.